Today's session will be on communicating bad news and collusion by Dr. Param. And the first session would be on for 40 to 45 minutes, and then we will have a discussion for about 15 minutes, and then it'll be followed by the case presentation, and we will wind up with the discussion on the case presentation. Hope you all have a really good afternoon with a lot of learnings. So over to you, Dr. Param.
Smriti ma'am, you wish to step in and...
No, I'm here to co-facilitate and assist Param. Nice to see everybody again.
Thank you, ma'am. Dr. Param, you can
Yeah.
go.
Thanks, Manisha, and thanks, Smriti. Yeah, we'll have a discussion. What I thought we'll do is my experience from last time. There's a lot of people who actually are quite active into this field in this audience. So instead of just presenting totally didactic and then going to discussion, I might just stop in the way and we can all have a good discussion. And because today's topic, although some of it was discussed in the last, always remains controversial because we'll go into those points. Let me just start sharing my things. And you please keep typing in between your queries, comments, and we'll take them up. And I think me and Smriti will keep a watch on that. All right. It's up there now?
Yes, sir, we can see it.
All right. Okay, so going to the objectives of today's session is predominantly about communicating bad news, or it's called by many names, breaking bad news and serious illness communication, but doesn't matter in the name. The idea is to convey adverse prognosis to the patient in the best possible way. And there are different prevalent models which people believe in, and all of them have their ups and downs. Then we'll talk about a bit of why it's required to be breaking bad news and dealing with collusion. In the end, we'll have some slides on dealing with emotion and possibly anger. So, as I said, the ideal method to do this exercise is still an unanswered question. We all who kind of work actively in communication still challenging cases keep coming through, and every day is a new patient, and it has to be individualized. There is no one size fits everyone kind of issue. That's because there are multiple factors: the background of the patient, cultural aspects. Although I mentioned Western and Eastern, they overlap. And even in our culture, there are different type of people, what they would want to do. Like, in the Western culture, a lot of stress is given on totally giving everything clearly and crisply, and nothing hidden in any manner, because it's mostly an individualistic culture, and everyone is responsible for themselves. Not too many joint families living together, not many joint finances. And sometimes people do heavily weigh in favor of quality of life than just quantity. In our culture, we're a little more interdependent and protective about our loved ones. Talking about death is still quite a bit of a taboo, and but it's still changing. And what I'm going to show you in some research which is done in this field, but we still have joint families. We still have joint finances. We live together, and so it's the individual patient plus the unit of the family which matters when we have to deal with such an adverse outcome communication. So it's all about getting the right balance and getting their anxieties and apprehensions under control. So as we keep saying these days that patients have the right to know, but we also need to know that patients have the right not to know. So we don't have to chase them with the adverse diagnosis if they're not willing. But of course, we need to know from them that if they don't want to know, who should we be talking to? So there are different ways people go about this There is a full disclosure model, as I said, which is more practiced in the Western societies, that it is complete disclosure. And unless the patient expressly says that I don't want to know, we are obliged to tell everything in that meeting. Then there's a balance between partial disclosure and then not disclosing, which we'll come to later. So what is the need for communicating bad news? I mean, it's very evident that if the person doesn't know, they have very short time to live. There's a lot of things happening. They may want to close their life's business and what's going around them, have a closure to many other things, interpersonal relationships, apologize to someone, talk to somebody while they can, and financial things like will and taking, like we saw in the last week, Vandana's case, that there was a lot of financial angle to that disclosure. And that can avoid hospital hopping, because if we give half-cooked information, then people will know something's wrong and we are not really telling them properly. So they might unnecessarily be going from one place to the others. And of course, for planning total care and palliative care and all those things, it's important that we have people on board, whether the patient or very close people from the family. So if you have any thoughts, just start writing down that do you believe in full disclosure, partial disclosure, or non-disclosure? We will come back to that in collusion again, so we can have the discussion that time. But this is the time to start knowing about what you think about. So I won't stop right now, unless there's already something there on the chat box, which I can see.
Nothing yet, Param.
Nothing yet. Yeah, I don't know. I'm just trying to get the chat here so that, no, I think I'll leave it to you. Yeah. All right. So that, as we said, we need to have something like an individualized disclosure model, depending upon what the patient would want, or our knowledge what the patient would want, if we haven't been able to discuss it with them. So something which is not in the slide, which I keep talking about and have been trying to practice for some time, is try to get this information, that whether the patient would want to know everything or not, very early, as early as possible. The moment we have a rapport with them, or sometimes even before that, because once the patient comes in, as healthcare workers, we have an idea that which way we are going. We may be going the downhill way. So we don't know the diagnosis. So we can be very upfront and honest that I don't know what you have. So you'll be needing investigations, and please tell me once the reports are there, do you want to be contacted directly, or is there anyone else you want to nominate? Could be friends or family. That works out very well, rather than having a report of a malignancy biopsy in your hand and then asking the patient that whether you want to know or not. So that is something I've been trying to use in these circumstances. So we'll start with when the patients want to know and how to go about that. Or it's somebody nominated that we know. So we are clear about who we need to talk to, and this is the way we go in those circumstances. So I'll come to the protocol, which we call it the SPIKE protocol, developed by the MD Anderson Hospital Cancer Center in 2000. That is being widely used, although there are many other being used, and I'm sure you must be using some of locally developed models and various models. So first thing is to tell them that still, even if they've agreed to know, just give a warning shot, as we say, that there is something is not good, and you still want to know, or you want to put someone else in charge. So that brings the appropriate atmosphere, and patient gets a chance to reconsider. Maybe somebody's brave when they walk in, yeah, I want to know everything. And then suddenly when you know that something is not good, you might want to reconsider, especially elderly may want to say that, okay, then talk to my son or daughter or whoever or spouse. So this is when the patient confirms. So now coming to SPIKES, Protocol of Serious Illness Communication. It's basically as an acronym on SPAKES. So S is the setting up of the thing. Depending upon our resources, we have different ways doing it. The ideal ones which you've seen is that near the ICU or the ward, or there is a special room which we call a family meeting room, where we talk about these things. It's not in the corridor where there's a lot of noise. There's a seating space. We are in a arm's distance of the patient or their attendant. If they have emotional breakdown or something, you can put a hand on them, give them a glass of water, give them a tissue or something like that. So the setting is very important. And today, in today's day, it's very important to have distractions put away, like a mobile phone, at least on silent or preferably switched off mode. Not too many people barging into the room and breaking the flow of the communication going on. And the way we sit, the way we position ourselves is also very important. As I said, we are near the patient, not across a big table as we talked last week. So this is a good setting. And then we need to know the patient perception. So even if they've said they want to know, we don't know how much they know already. Maybe somebody has passed them the news some days back, and they've come to know from the lab directly. And the way we deal with them is different. They already have, for them, the knowledge is there. They may have a lot of questions. So we may not spend too much time giving them slow diagnosis if they really know the prognosis. So getting the patient perception is very important. How much do you know, and what is it you know about? Tell me what you know about what's happening around here. Just give an idea. The invitation is, as I said, to disclose that we've already talked about before, most likely when we come to Spike's meeting, but again, no harm asking that this is it. As I said, do you want me to go ahead with the knowledge, or you want to call in someone? And then the knowledge, and knowledge is again a very important. We talked in last week in general communication points, that it has to be clear, non-technical, no medical jargon, slow, as we say, chunk and check. Chunk and check, that means give us small information. There is something on your x-ray, then stop and see how they're taking it. It doesn't look good. Then go on to that. It could be a tumor, and it could be a infection, but unfortunately your report has come out like this. So this is slowly going back and checking if they've understood, or they want us to stop. These are non-verbal cues. We know where somebody starts crying or stops. There is no rush to give them the diagnosis immediately. So in giving knowledge, what we call sometimes in any communication is ABC is very important: accuracy, brevity, and clarity. So the next is, of course, once we told them, goes to the empathy stage. Once they have, sad emotion or breakdown, they want to keep quiet or just start looking into the abyss, and they are lost. So many people can react differently, and we need to be emotionally prepared to handle it with compassion and empathy, and maybe, as he said, gentle physical touch, and waiting. Giving gaps in waiting is very important. Silence can be difficult, but it is sometimes very, very useful in that. Then comes the strategy for future. Means the plan once it is done with. So the most important thing in strategy is that unless it's a dire emergency to be done tonight or tomorrow, we can always wait. Many people don't want to talk about plans immediately. They want to absorb information, go back. Maybe you can go out of the room, come back in an hour's time, or they can go home and come back, and we can say anytime. We can give them some literature, which we already have, and then they can come back and talk to us about at their convenience anytime. Sometimes the patient may not be wanting to go, or they have not booked their bus or car for a long time, and it's a good idea we keep a free time so that we can be with them for another 15-20 minutes, half an hour, if they are in an emotional state, especially if they've come alone. So keeping that window open is a good idea. So as I said, in the strategy, then it comes that patient, we want to know how much time I have, very important. And sometimes we may have a fair idea, sometimes we may not. So this is very important, that if we don't know, not try to sound over sure about things. We can say, we'll take it as a time. This is what we are going to try. These are the options we can try discussing with you. And on that basis, we can take it in the next few days. This is a small video which is made for that, trying to inculcate most of the spikes. It is not ideal because this is from the time when I was actually getting into the communication thing. So this is one of my residents who I've got a diagnosis of motor neuron disease. As some of you may know, it's a extremely serious prognosis, like there is paralysis going on to sometimes death and disability to a huge extent. It's a almost a non-curable disease, and it's something which we fear in neurology. So this patient had come last week and done some tests, and now he's coming back for the tests. Because of time, I've cut out the gaps in between, so it may not sound very ideal. But let's.
Kaise ho? I'm good, sir. In fact, the last medication you gave me worked wonders for me. My twitching has improved by 80%. And regarding my muscle weakness, I'm feeling improvement in that too.
Yeah, I have your reports here. उसके बारे में बात करेंगे. तुम्हें क्या लगता है अपनी बीमारी के बारे में, क्या फीलिंग हो रही है? कुछ आइडिया है?
No, what I think last time we had discussed about that. You told it's some weakness in the nerves. So, in fact, after taking the medication, I feel it was just because of after my fever. So, I guess I'll be back to my full power in another week or so.
Okay, we actually will go into the reports. Do you have somebody with you want to call in, or you want me to explain everything to you, including the diagnosis, the prognosis, and what is going to be the future of this illness?
Oh, no, I've come alone. You can tell me what's the matter.
I'm saying so because unfortunately I don't have very good news based on these reports. It's true that it's a nerve disease, as we discussed last time, but after doing the electrophysiological test, we have come to a diagnosis which we call as motor neuron disease. It is a nerve disease. It affects the neurons and it makes them weak, and sometimes they degenerate. The problem is that this disease is not a short-term disease. It's a long-term disease and usually progresses over the coming days and months and years.
There must be mistaken here, because I just have a very mild symptoms of bit weakness, a bit twitching. That guy, I guess, was wheelchair bound, and like I think there must be a mistake here.
We can repeat your test anytime. It's not a big test, but from the reports we have now and our electrophysiology team we have discussed, we are not much in doubt that it could be anything else apart from motor neuron disease. You don't have to be, everybody with motor neuron disease does not become wheelchair bound immediately. That was the latest stage of disease which we see in Stephen Hawking and all. But in early type, like you are likely to be physically active for quite a long time.
Yeah, that's what you need to understand, Doc. I have just been married. It's been just a month. Okay, and all this while, on all these 30 years, I have just been looking forward for earning and taking care of my family. It's my time to enjoy my life, and I don't think so. I'm ready for this thing right now.
I know, I can understand that. I wish I could tell you things were better than this, but we could sit and discuss what are the possibilities. It may not be a cure, but which can support you to move and be ambulatory or keep moving and keep working for a longer period of time. We don't have to do it now. You could come back and we could think about what all the medications we could be using.
Yeah, definitely. I think it's too much for me to take right now. I think I'll take some time to.
Okay, so this is sort of an amateur video, and there are loopholes in this. It'll be nice if people can point out the points we missed in this. Although A lot of the positive points are there, but there are few things which can be, found wanting. So it'd be nice in your comments if we can have that. Smriti, do we need to talk about anything, or are we good?
I think we're good for now, Param. There's been quite a few responses that came in earlier.
Mhm.
And there's one in particular that I'll circle back to towards the end, because now we're talking
Okay.
about collusion, and that comment does have something to do with that. So
All right. Yeah,
I'll
we
loop
do
it
it
back.
after the collusion. Thanks. Yeah. Yeah. So what is collusion? As many of you may know, so collusion is a word used when we, for some reason or the other, are either silent or we've been asked to be silent about the disease, and mostly it is the patient's attendants who are scared that the diagnosis should not be told to the patient. They may not be able to bear it, or they may become very depressed, which it is true. That is why the controversy. It is true, but it's also important to balance it with the patient's right to know, for the reasons we've already talked about, why it might be important for the patient to know. I was reading an article in one of the journals where there was like the three-way collusion. Um, so the old lady, before that the son came in, and it's somebody's case report. Son came in and said that my mother doesn't know, so please don't tell her, she will break her heart and spirit. And so the doctor didn't feel there was a very good idea. So when the mother came in, he sent the son out for some get this medicine. And then he asked the lady how's she doing, and she said, I have a terminal disease. Answer, but please don't tell my son doesn't know about this. I don't, he already has a lot of burden of his own. I don't want to burden him for the longest time possible. So it can, it can go both ways. Collusion can happen, but usually it is what we face is the patient's family or attendants not wanting us to talk about the diagnosis. They want to protect the loved one from us, or what you mean is from the bad diagnosis, but we need their help, and they need our help to it has to be a team to go through the palliative process. If it is not a curative, or even if it's a chronic disease, not terminal, still we need to go through it together. Because just to give a bit of a background, in before 1970s, from again a journal, most physicians used to consider it inhumane to disclose bad news to the patient that they were dying. So it was actually not even talked by our community, by the healthcare, nursing, doctors, or community that to talk about. So, so, so although the patients may be thinking, there was a time when even the healthcare providers were thinking the same way. But the things are changing, and there are a lot of reasons for that. One is, of course, palliative care being available. It's not that the moment you tell bad news, it's thank you, and patient is left to fend for themselves. So in places where palliative care, there is symptomatic treatment. There are experimental treatments coming up which could be tried, for which you need really the patient's support, and perception is very much important. So this is the reason why these things, and more even in our culture, there's more individualism. We see a lot of nuclear families, a lot of people who are family but not meeting very often or not get along very well. So there has to be, the patient may have to have more individual knowledge rather than as a family exercise. Then our expectations from life have gone up with the coming affluence and money. Our bucket lists have gone up, and we may have some things to tick in that. And if they don't know, how will they do it? And another is the physician angle, as we I think talked last about physicians who find it difficult to give back bad news. So physicians or any kind of other nursing and healthcare providers, we are all geared to save lives, and which is not wrong. Obviously, that is what we do. But in that passion, talking about death is considered quite a failure, like a failure of ourselves, and that is why a lot of medical professionals are not very well versed with how to talk about death, as in the society we talked about, and may unduly prolong harsh treatment if you really don't tackle it well. And in the end, there is a the document is not there, but it's in the health ministry website. Legal requirements, we are not encouraging, even in our country, to tell more and more clearly to the patient. And if we don't disclose, unless the patient expressly says that you tell somebody else, I don't want to know, it may be taken as a negligence of our duty towards the patient. So yeah, so I think we'll stop here and maybe have a bit of a discussion, and then I go on to the next few slides which are left. Yeah, Smriti, do you think
Yeah,
it's
so
good time?
yeah, I think that's a good idea. I want to come back to a comment that Amala had made, that issues around disclosure of information pose many dilemmas for healthcare workers. And the answer is that in exceptional circumstances, you may override your duty of confidentiality to patients or clients if it is done to protect their best interest or best interest of the public. That is something that we follow in mental health practice, where confidentiality is breached if someone is displaying suicidal, homicidal ideation, or if you're called upon by a court of law. I don't know if that applies in this sort of a setting, Param, when we're talking about prognostication in terms of serious illness. So what do you have to say about that? And then I'll come back to some of the other issues that people have talked about.
Okay. So yeah, so it's between our duty and emotionality and legality, there has to be a balance, absolutely. And in confidentiality, that is very important. That is the reason we want, as far as possible, the patient to nominate people. And over time, there used to be people calling up to the hospital, say, what's wrong with this patient? I'm his uncle and talking from abroad and this thing, and we used to kind of tell everything. These days, we don't want to do that unless we have a permission from a patient, and they make a stop. They call up them and they give us the phone and we tell them, because confidential becoming quite an important issue, and rightly so, not only in the psychiatric diagnosis, even otherwise. But sometimes, as I think you were mentioning, competence, which we can't discuss everything in the session. So competence to know and make decision is very important. In those cases where the patient is either considered mentally, physically, or because of dementia, unable to take the news or make an informed decision, that is where we can, on our own, bypass our duty to talk to the patient and then go to the next of the kin. Or as we talked last time, if we don't trust people or we have doubts or people are not there, we as per the rules, either the hospital or city administration or the magistrate is brought in. Especially most of the Western countries, magistrates do a lot of this job as being, power of attorney of the patient is given to them because there's nobody else. So yes, it is complicated. I totally agree, but we are trying to find ways and means of doing it the best we can. Did I get it right? The question.
I think
was
I
something
think
else?
I think you did. Also in India, we have, somebody goes in and gets a diagnosis or prognosis, then the family will call some senior doctor somewhere else, get that doctor to make a call to this doctor, and then so there's all that happens a lot in our culture, right? Where, oh, my brother-in-law's friend is a doctor, so this is what he said, and this is the information he wants. So then, um, I'd like to point out that also in collusion and disclosure and stuff, we're also dealing with a couple of other things, which is the patient's sense of autonomy. And what I think Param will be covering perhaps a little later, we can come back to it, is the idea of realistic and unrealistic hope. So those are important layers to the collusion process, which I'm sure we'll touch upon. There was one, you had asked for some feedback about the video, and you also had told us that, because of time constraints, you had cut out the silences and all of that. Someone felt that you were a little blunt in your communication.
Yeah.
So yeah, you
So
want to just take that up.
absolutely. No, some of them been cut, but some of them we were learning. This is the first video I ever made this thing. And I think both me and my residents were quite tense trying to make a video. We are not actors. So yeah, but absolutely right. That's spot on. So the chunk and check part is missing. Although initially it's a 7 minutes video, there is a bit of waiting, but in this video, absolutely right. So that coming to the chunk and check, that is well caught. So that part should be there. Yeah.
Also, somebody has brought up empathy, and this is something I've struggled with for many years in my practice, because when I ask people what is empathy, they say seeing the world, I mean, walking a mile in someone else's shoes, or seeing the world through somebody else's eyes. I'd like to make a very clear distinction between empathy, where you lose yourself in the other person's worldview. If, as a professional, as a competent care provider, you start seeing the world exactly as your patient does, you lose the objectivity to help them navigate and problem solve. So empathy is great in the sense that you enter somebody else's worldview and you see it as they would see it, but it's not, you don't put yourself in their shoes. I personally, this is a personal opinion, I don't think we can ever put ourselves completely in somebody else's shoes. We can imagine it, but we can't put ourselves there. And even if two people have had similar experiences, there are experiences within experiences that make them different. So it is really important. Like if I have lost a loved one and you have lost a loved one, I can't pretend that I understand exactly what you were going through because your dynamics are different. So please be cautious about how the word empathy is used. And we as care providers have a duty of care where we assist them to find solutions that are best suited to them, not what I would think I would do if I was in that place. So I just wanted to make that distinction.
Absolutely right, Smriti. So this is a fine line, difficult to really put in words. You've done it very well. So instead of totally joining issues with people, like that you lost somebody, I lost somebody, what I'd say is if you put in a broader perspective, that I can feel that you must be feeling really bad about this, and this is a bad time, and that is totally understandable. That might be a little more, desirable than saying that I am totally feeling what you're feeling, and I went through this, and this was these things, like we do in some other forums. We don't want to join issues and comment with that. We only talk about the general, broader. Empathy has to be a little broader, but there has to be a distinction between, starting crying with the patient sitting together and all. Sometimes it could happen, sometimes you can't. These rules can't be, put in stone. But yes, overall, it should be that, because the person may want empathy from you, but many times patients attended want a bit of authority from you, a bit of a stronger support, that you are the doctor, you need to be strong. They don't expect us to be getting into the same emotional state where they are. So yeah, it's a balance. I mean, I don't think we can have a score on it, but that's the general thing, what you said, and what I would.
Yeah. And Amala, of course, has talked about collusion being a universal phenomenon across cultures. Absolutely right. And issues of illness, recurrence, deterioration, and palliative treatment, yes. Also, I think very often what happens is when we talk about breaking bad news, we think of bad news being as, oh, it's a terminal prognostication, or the person is not going to recover. But breaking bad news can even be what, like we said, what we call breakpoint conversations, where the time in the illness where the person is no longer able to perform certain tasks, if their mobility is irreversibly impaired, or they can no longer go to work as a result of it. Those breakpoint conversations are also bad news. Breaking bad news does not only have to do with conveying that the illness is terminal. So that's also something for us to remember.
Yeah, like in this patient, Smriti, it was not a lethal disease, but the patient was going to be bed bound in few years' time, and this was way far, but it was the starting point of a journey. I think what we were saying here is that where a life-changing event occurs.
Yeah,
so
exactly.
you're, as you say, as I say, that you're on a cruise control in life, and suddenly you have a crash and you need to change course. So it's a major change in course also is something we need to talk about, not only death in that case. Absolutely right. There's someone who said, yeah, I mean, it is in all cultures. It's just a little different that we are a little more closer knit with joint families. So a lot of things come in. Father is spending for the son, brother is spending for the brother, the uncle is spending for the nephew because the brother is gone. So it's a little more. So it's as I said, it is cross-cultural. It's not only one culture. And then there's another question about, can you talk about cultural aspects? So yeah, I mean, I think I talked about a little about this cultural aspects because of the joint finances and not talking about death and longevity, and having, in many of Indian cultures, there is Think about having your, even if patient is on the bed all the time, one of your grandparents or parents, and having them in the house is considered a very good omen, and sometimes we may forget about their sufferings in that having, sitting, my grandfather sitting is a big support for me. I see a lot of people talking in our culture here in North India, that just them being there. So yes, it is cultural, but of course, the crux remains that patient autonomy, as far as possible, needs to be respected. We are going into those advanced care plans. We can't talk about that in today's session. That in many countries, as you all know, there are advanced care plans, and I worked there, and the moment a sick patient or an elderly patient came in, it was on the top of the file, what to do, what not to do.
Yeah.
And there are people, including Pallium group and other team, working on those things, end of life, and getting it done. But I'm not sure if we still have a complete legal sanction on it. It's work in progress. And once it comes, I think it will help us make our decisions more easier. And
Also, there is a filter in terms of, I'm coming back to this question of cultural aspects of communicating sad news. Depending on which culture or context you're in, uh, there is a channel of communication, and that is determined by gender, it is determined by age. We don't, um, young people, minors, are really not the people who get spoken to, right? And you find that as people get older, we take away their autonomy. We're not going to let somebody make decisions for our 85-year-old grandmother, although she's lived her life and she's probably been a very strong, independent woman. There are aspects where the woman is not the one who's allowed to make a decision. So all the communication is with the, with the male in the family or whatever. So there are different lenses that come in, and it's really up to us to educate ourselves about the background that our patients and their families come from. The onus is on us, and being culture sensitive is really our responsibility. There is also, like, in terms of touch, eye contact, expression of emotion, encouraging people to talk. I've seen many cases in which the patient is a woman and she's sitting there, but the healthcare provider will talk, to somebody else there, even though the question is coming from here. Or if it's a child, we will talk over the child to the adult, and talk about the child in third person, not even like he's in the room, right? So there's a lot of those cultural differences. We need to be sensitive to it, and we should make sure that we're not contributing to toxic modes of communication like that. And Nivin, this is a simulation. The video was a simulation, so I think it was full consent and awareness of everybody present.
So it's not a patient, actually. If you're talking about my video, it's one of my residents, and we mainly made it for the course we do in PGI and other neurology circles. So so that, but I understand your concern.
Thank you.
Seeking permission is very important. And the last one is, before I go back to the slides, is Amala is saying that patient has a right to be full explanation as more as they want to know. Of course, that is our prime aim of all these conversations, is that if you have the patient, so that is why a rapport and early talking of these issues is very important. If the patient has a view on this, we totally go by the view patient the way, because our point of contact is the patient. These issues arise when patient is not clear about things, and sorry, the patient is not wanting to know, or there is not contact with the patient. Many times you end up family only coming to you with the reports. So these issues can arise that time. But I totally agree with you. So maybe if there's anything left, we can come back to it. I'll just finish off the slides here. Okay, so there are some tips, though, that if the family is, although as professionals we feel that is not a great idea to collude and keep, and as I said, because of our different cultures, there may be somebody else spending for money for the treatment. There may be somebody else who will be the caregiver of the person, because how many nursing homes do we have here, or the state-sponsored things for elderly care? So because of the different resources and different logistics, Sometimes we may need to go, may not be totally, but try to have the family on our side. So we do not challenge their belief immediately. No, 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 tell them, tell them. There must be a process where we take them through all this. So initially, it's okay to agree with them, but we agree with your anxieties, and then once we have a rapport with them, we calm their anxiety. Then we get a chance to provide them, with some information and give them our point of view. How do we go about it with all the reasons which I have brought out in the slides? We can tell them also why this is important. Your father may have somebody's money to give, somebody to talk to, and all these things. And ultimately, and of course, with some data is very important. So we have now have, thankfully, a lot of studies going on. One of this I'm just quoting here is that from a cancer patient who wanted to know. So it could be just a myth among the family or the culture that patient doesn't want to know. Those people may want to know. So this is in one set. It may be a little high, but then, yeah, it is shown in the studies about 94% of people wanted to know if their illness was cancer in this study. And about 85% wanted to know the time limit they had, prognosis, how much time was left. So it's quite a high number, which we can share with the family and see, are you sure they don't want to know? I mean, it does not think that it's okay for me to tolerate, but my wife or father or mother cannot tolerate. It may be a myth, but only if we have their trust in us, we can tell them these things and bring them around to having a more holistic kind of approach to this exercise. So the last thing, emotion was there. So I thought I'll mention a little bit about anger also, because anger situations keep coming up quite often these days, more and more, especially with violence and, in the nursing homes and hospitals. So these situations, and we have to be now, uh, trained or knowledgeable about how to deal about these things, because uh, if the anger is not managed in time, it can turn to, as I've written here, rage. So rage is an emotion where thinking capacity is bypassed, as we keep saying that our emotional or limbic system takes over and our thinking mind shuts down, and and it can become very damaging for everybody. So if there is some situation like that, whereas a patient or the relative is very agitated, and it may fall upon anybody, administrator, doctor, nursing professional, whoever is there at that time to deal with that. So facilitating, letting the anger flow away is very important. Listening, respectfully listening to them without interrupting, and telling them that you seem do upset, tell me why you are. Inviting them to tell them can diffuse the situation initially already, and then stand up and listen if they're standing, not keep sitting on our office chair, um, and maybe in a respectful position with the eye contact where required. But of course, to be on the safer side, be a little distant so that there can't be immediate physical violence. Or if it's a very bad situation, even have the security standby. So once that is done, and to add to that, what I recommend people doing is that they can always tell that if you are not satisfied with me, there is a complaint book, which will be a third person looking at you can go and complain there. So once they know that we are not totally antagonistic to them and we are facilitating what their issue is, their anger might come down automatically. Once it's done, then we sit down and resolve the situation and maybe correct the correctables. As I mentioned those 4 C's last time, which is my mnemonic for communication. 2 added C's for conflict resolution are being calm. So we respond as per required, not react. Sometimes they can be angry and derogatory comments may be made. And if we react to that, situation can get worse. So this is where we need to show maturity and find commonality. That is means finding common ground. Something like that, we know that your patient is not getting a bed in the ICU, and that is why you are angry, and we agree to you that it is required. And we are trying our best. We've assessed them, put them on the waiting list, but there is a set procedure. And unfortunately, it's the truth of our hospital or whatever, wherever we are working, that there is a limited supply and demand. There is always a difference. And let's see, your patient was on a ventilator or an ICU bed. We would not push you out to get a new patient. Similarly, we have to do this. So it's a common ground. We it's not that we are just, laughing, oh, what can I do about it? I don't create bed. I can't buy a bed for you. That kind of a thing can really worsen things. So you are right in expectations, but in the same way saying that it's not a personal mistake or negligence on our part not to give you that. So this is a common ground we need to achieve. I think I'm finished, Priti, with the framework which I was given. So there are some things you mentioned which may not be part of this thing. But if there are any questions, we can take up on that if you had something in mind, or somebody can email me also, and I'm happy to always respond to that. So I'll stop the presentation here, and we can take up the undiscussed issues now before the case presents. Something will be discussed in the case also. There is a very nice case to be presented, but yeah, till we have time we have about 10 minutes or so before the case. So yeah, carry on. Smriti, over to you.
Thank you, Param. So yeah, you've made some very valid points. I was logged out in between, so I've lost some of the chat. But Vandana has made a very relevant point of involving the caregiver and eliciting their concerns and addressing them. This and something that we've talked about in the past, Param, is that whenever we are faced with a difficult patient, and I'm going to ask people to put in the chat box who they consider a difficult patient or a difficult family, because we've all, there's always that one or two. There are people who come in and you're like, oh gosh, this is going to be a difficult conversation, or I mean, there are patients who trust you. You manage to have that rapport with them, but there are always patients and families who, even if they've been with you for a long time, that this is going to be a less than easy conversation. So I just want to invite people to mention in the chat box who you find challenging when you're working in your work environment. Teenage patients, anyone, and please keep the answers coming. Who do you find challenging in your work setting to talk to?
I mean, although there are some things about how we say it. We call it challenging situations. I attend the communication international meetings, and things are saying that we should not call it challenging challenging communication. But of course it is. We can be difficult sometimes. Anyone can be difficult sometimes. Especially, when I have seen that people who come from places or countries, like the son is coming from somewhere where there is a great healthcare and the population is not like that, and suddenly they would be expecting, it's not like a black or white, right or wrong situation, but they expect, my father has been a very honest government servant and now he's 80, the state should be taking care of them, and this is what he gets after paying all the taxes, and so many people are not paying taxes. So they're right, but actually this is a systemic thing. So but the system is not going to come and talk about it. So that time we are representing the whole country in the health system then. So yes, it can be difficult. Those people can create a difficult situation, but that is where all these skills will come in handy.
Yeah, absolutely. And if the person serves the internet, our biggest challenge is actually Dr. Google sometimes, because we're up against the entire force of the internet. And really, your 5 years in medical college doesn't mean anything. Patients who are stubborn, keep putting up their own opinions, opinionated people, people who are probably not good listeners, and families with a single breadwinner. Yeah, a lot of pressure on that one person. Patient who feels it is your right to help them out. So a sense of entitlement. Also, we have people who enter the healthcare system and then have a lot of connections. And so suddenly there's a lot of pressure on the healthcare team because some very important local politician has gotten involved, or this is someone's cousin, some ministers, somebody. So that becomes very difficult, and there's a sense of entitlement. So yes, let's not shy away from, I know sometimes there's this hesitation to talk about things that are distressing to us as healthcare providers, but we need to talk about it and openly address it. This is by no means a place where we're complaining about. This is just the reality of it. Um, okay. Avatar, we'll talk about depression a little further down in the series, because that's a very, that's a very, there's a lot to navigate there. Um,
And
what I convey especially.
Vandana's mentioned something regarding the caregivers' concerns and difficulty in communicating or not being able to say it. That's right. I mean, where do the caregivers come from? Society. We have the same biases sometimes. So it's not that we
Yeah.
cross over to the other side. So I totally agree, Vandana, that sometimes if we are not proper, that is the reason for all this training. Because otherwise we are coming from the same place, and we may have difficulty in talking about death and bias, or saying it clearly. So you're right. Absolutely, we need to take that, and that is where all this sensitization and training comes in place. That at least we are in a profession where we will be facing death, and we should be able to talk about it.
Yeah, so I will also mention that, whether it's the patient presenting or the family who's angry or concerned, or why would somebody be surfing the internet so much? Because quite often they haven't received that information in a way that they have understood it from the person who should have been giving them the information. And so you fill in the gaps in your understanding by going online, and then you find all sorts of, half knowledge is dangerous, right? And psychologists on the forum will understand the need for gestalt, where the sum is greater than the whole of its parts, where you need to understand what's happening. So lack of information, lack of clear information, lack of maybe the information was given, but it was given in a rushed way. It was given when the patient and the caregiver were not emotionally ready to receive it, or they were so distraught by the information that they were not able to completely understand it. So gaps in information, gaps in, not speaking to the patient in a language that is understandable to them, or using a lot of jargon. Sometimes, the greatest illusion about communication is that it has taken place. We think we have communicated with somebody when the loop is not closed. Also, when we have angry patients, like Param and I have talked about it several times before, maybe in other forums, is that behind anger is always fear.
Fear. Yeah, you keep saying that. I know. I like that comment. Yeah.
So, what is making you afraid? What is making you so afraid that you're lashing out in fear? Not everybody is okay with being vulnerable and saying, "Listen, I'm going through a really hard time right now. I need you to help me understand." Sometimes that vulnerability comes out as anger. So, at that moment, perhaps it's good for us to take a step and say, "Okay, right now this person's really angry and yelling at me, but they're also probably really scared. So try and get to what is making them scared, address that, and then the anger comes down." Vandana, you want to say
Absolutely.
something?
Yeah.
Actually, I wanted to share an incident since we have time. So, I once had a patient who was, told that he has stage 4. He was a teacher from Bihar, and when he came to me, he was so angry, and like I wrote on the chat, he said, "I've been so righteous all my life. I don't deserve this. I have contributed to the society. I've been a good human being. I am going to commit suicide." It took me 2 hours with that patient, and to explain to him, to kind of pacify him. And when he came for his follow-up, it was a great sense of satisfaction for me when he said to the oncologist that it's all thanks to madam that I haven't committed suicide. So the sense of being cheated, the sense of being karmas, being responsible, what did I do wrong, also affects patients negatively a lot of time. So this is what I wanted to share.
Absolutely right, Vandana. Yeah, you possibly successfully took him through the Kubler curve. Yeah, so he was in severe depression, and that helped him. So I think at some point of time in depression during the course, that will also be discussed. I think we are heading towards the case time. So what I would, if I have to say something towards all this is, and what I would tell the trainees in the communication, and this we need to deal with these situations. Of course, the patients were way out of line. We don't want to tell. Sometimes there are various thoughts in communication teaching that no, patient is never out of line. You have to do. I personally have a view that inside us, there's no harm knowing that this patient is out of line. You are doing your best, and still this patient is blaming you. They are difficult, as you all have put down in this list. There are the situations, but we need to deal them like we deal with our children. So that is a example I always keep giving, because parents, especially in our setup, deal with a lot of nonsense from the children. It's a one way thing. The way we love our children, or the way our parents loved us, we don't love them back. So it's a maturity which comes with being a parent, or something which you learn to be patient even with the misbehavior, you can call it, or rudeness, or something which comes from sometimes from your next generation. So if we keep that in mind, that these are the people in this situation, they are like my children, they are immature, they don't know what I know, they are out of their comfort zone. I am in my hospital where I work every day, I get paid for this. They are out of their comfort zone, so they are out of line, I know. But the way to tackle is not telling them they are out of line. The way to tackle is, as Priti said, find out why they are out of line. Very few people, I believe, are actually bad, as you call it. It's where they're coming from a different place. Somebody's scared, someone's not having the money to pay for the treatment. That is what is making them behave in a very aggressive manner. Somebody's not getting leave, they're here from abroad for 10 days, and they expected their dad will be out of the hospital and he's still there. So they have their own reasons, and they're trying to blame it, as human nature, blaming it on something else. We are the people who need to understand that. We don't expect them to understand us. So, of course, I'm not talking about, it is a physical violence. I already said you have to be a system in place. We don't want us to get hit. Beyond that, we need to have a thick skin.
Yeah, absolutely, Param. Very well said. And before we go over to Ramalakshmi's presentation, just a final thought on this particular part of the discussion is, um, I would urge everybody also to do a little bit of reflection on what makes us uncomfortable. Where are our boundaries? There are many people here who, the minute somebody raises their voice, automatically all our defenses are up. Some people may not be really comfortable being around someone who's weeping uncontrollably. We need to know what our boundaries are. We need to know what we are comfortable with, where we start feeling the discomfort, because quite often in an emotionally volatile situation, we end up projecting a lot of our thoughts and ideas and assumptions into the situation. So self-reflection is very, very essential for a healthcare provider, because otherwise we're just on autopilot, and that really doesn't help anybody. So having said that, I'm going to now move along to Ram Lakshmi. Welcome. Manisha, are you going to be controlling the slide?
No, ma'am, she would be sharing the slide from her side.
Great.
Ram Lakshmi, you're not audible.
Hear me?
Yeah.
Yeah.
Carry on.
Okay. First of all, I have to thank Pallium for giving this opportunity to share my case presentation. Uh, Today, I'll be presenting a case of a child patient who's 11 years old. At the age of 3, he was diagnosed with a skin condition called ichthyosis vulgaris. It's a skin condition where the skin does not shed the dead skin cells. So rather, the dead skin cells get accumulated in the top layer of the skin itself. To be precise, the skin looks like a fish scale. So for this 11-year-old boy, skin looks like a fish scale. Then because of that, he was having skin itching. Then at the age of 11, he was diagnosed with T-cell lymphoma. It's a type of a cancer due to which he was having body pain, loss of appetite, and low hemoglobin. Then we'll come to the insight. Diagnosis, the patient was aware of the skin condition, but not the T-cell lymphoma. Family was aware of both the illnesses. This is where breaking the bad news or communicating the bad news plays an important role. Now I just want to share about my experience of how I communicated the bad news to the family. Just imagine this scenario. So the child and the child patient family were in a general ward. I took them to a separate room. Initially, I greeted them. I want to make them feel comfortable. Then I began to ask questions like, did doctor tell you something? Do you know why the child is admitted here? These kind of questions were asked to the parents to know how much information they know. So this was my starting questions. They had no idea. They want to know about more about the illness. They were so eager to know. Meanwhile, the mother started crying, tears. I could see her tears in the eyes. Then since they wanted to know more, I started to reveal the diagnosis, gave them a warning shot, like your child seemed to have a swelling, which is not the usual type. It looks like a swelling which is not operable. So, on listening to this, both the parents were shocked. They wanted to know more again, but they didn't deny to know the information. So, I gave them a pause. I wanted to see the reactions, everything. After observing the reaction, I communicated the bad news that your child is diagnosed with T-cell lymphoma. It's a type of a cancer. So mother literally started crying. So meanwhile, I patted her back. I hold her hand. I gave her time to ventilate her feelings. Uh, Father was so confused on seeing the wife crying, on listening to the diagnosis. He put his head down and he was sitting like that for past 5 minutes. He sat putting his head down. Mother was crying, saying, why this happened to my child, everything. um, I gave them time to ventilate their feelings, acknowledge their feelings, and at the end, to reassure their feelings, I also said we always be there for your family. Is there anything you want to ask more? So this is when the mother immediately came up. Please don't tell the diagnosis to my child. So this is where the collusion plays an important role. She was telling, since the skin disease itself was affecting my child so much that he couldn't take it up, he'll be very depressed. Please don't tell my child this diagnosis. So we had a discussion, the parents and counselor, the health workers and the oncologist. Since it's a child patient, consent of the parent is very important. So they were so determined that the diagnosis should not be revealed to the child. So we accepted the um, we not accepted we in combination of the oncologist, the counselor and the parents, we came to a conclusion that not to disclose the diagnosis to the child. I just tell about the family overview. Mr. X is a farmer. The child patient father was a farmer and mother was a housewife. Child X had a sibling who is 8 years old. Um, They were from a village in north of Tamil Nadu. Since he's a farmer, he couldn't earn much, and this pandemic made their life even more challenging as the father couldn't go for his work. Ecomap, yes, for the child X, the school going to school was very difficult because he was bullied by his friends due to his skin condition. So he was very scared to go to the school initially. Then with the parents support he started to going, but he didn't have any friends. And though he was interested in sports, his body condition did not allow him to portray his talent. Then occupation for the father was difficult. There was no regular income. Extended family also didn't support them. The, and also hospital, since it's in a village, they couldn't find a hospital near the town. They have near their village, they have to go to the main town to take the child every time. um, Socioeconomic overview, they are economically very poor even to provide nutritious food to the child, and they have to travel from their native to Chennai for treatment every time. So that was very difficult for them. As I told, there's no regular income. uh, there also pressure from private money lenders, which gave them a whole lot of stress because they have borrowed so much money from outside for the medications, for the travel expenses of the child. So financially, they were drained. Um, Psychospiritual overview, mother was depressed as she couldn't see her 11-year-old child suffering with the pain, and the child was lost his interest in go to school as he was bullied by peers and he couldn't play that much. The main important thing was he was fear of the, I could see the fear of needles in him met the patient in person, because he was pricked so many times as the doctors couldn't find the veins to inject. For cancer, they have to inject the medicines, but since he's having the skin condition, they couldn't find nerves to inject. So for every hour, they used to prick and see whether they could inject the medicine. So that was so painful to the child that one day he told to his mother, "How can you see my suffering? Please kill me." That was the thing which shocked me. And the mother was in tears saying, "Why God gave this suffering to my son in this age?" See, as a child, saying this is not an easy thing. This has affected him so much, the pain. That is why he was so depressed and so sad that he was so afraid of the doctors. If a doctor, see, when I met him for the first time, he thought I was a doctor, and he refused to even see me. He literally refused to see me and told his mother, "Please ask them not to come near me. Please tell them not to inject." So that was the condition. Father, to an extent, had a great acceptance about the condition, but he was worried that he couldn't meet the financial expenses for the child. This was the total pain: physical pain because he was vomiting, body pain, loss of appetite, loss of weight. Psychological issue: both mother and the child was depressed. Mother had whether the fear of death about the child, traumatized, and there was a guilt in the parents because they thought, see, they took the child to the hospital in the last stage in spite of seeing a swelling at the back of the child. So there was a guilt, maybe we should have taken the child earlier to the hospital. That was there. Socioeconomic challenges like difficulty in repaying the debts, nutritious food, medical expenses, travel expenses. Spiritual, the mother was telling, why my child has to suffer with these illnesses. So I could find sense of hopelessness. Mm, Interventions as such for the child, since you this intervention will not happen immediately. It took over a period of time for me to build a rapport. What I explained how to communicate the bad news was just explanation will be for just 5 minutes, but in reality, it took me about 1.5 hours to communicate the bad news. It took me so many days to build a rapport with the child. Then I found his interest. Then I involved him in few play therapy, art therapy. Then only I gained that rapport with the child. So counseling for the parents was done, for the mother especially. Mm, then we tried to support them financially for their travel expenses from the native to the hospital in Chennai, medical also, and monthly groceries. Physical aspects, to reduce the pain, doctors are giving morphine to him. So this is about the condition of the child, and this is how I, as a counselor, communicated the bad news to the child patient family. Now I give to the participants for the discussion. How would you break the bad news to the family? If there's any loophole in my communication, please let me know. I can also learn from you all.
So do you want to take this question by question, Ram Lakshmi, or shall we
Yes.
just
Yeah,
all right.
question by question or whatever is convenient. I am fine with anything.
Maybe, can I start with the thing? So, did we end up in the end? Maybe I missed the child telling the child or not?
No, we didn't tell the child because the parents were so determined not to tell the child. Being a child patient, I felt that consent of the parents is more important also. So I don't know whether I'm wrong, correct or wrong.
No,
So I felt that.
this is something. I mean, if you want your video, you could stop sharing the slide. Maybe then we will.
Yeah,
I don't know.
yeah.
Afterward. So yeah, so this is something actually I wanted to know from because I don't deal with I'm adult neurologist and dealing with small children. Although academically as part of communication, sometimes we talk about it. So I think for me also and maybe other people, it's good to know that um, where and what time, at what stage do people get ready to tell their kids, or mostly it is that till the end. The child, I'm 11 years old, is not a very young child. Sometimes they may be 12, 13, and same things might happen. So do you people feel they have the right to know, or is it okay to go with the family? And does it change over time? Because as you were talking about the case, I was totally being able to understand the parents' view that they are under so much shock, they won't even think about telling it to their child. But maybe if it's over a few months' time, sometimes people may feel that, well, this person is an individual and may have the right to know about some time. So how does it go usually in when you're counseling children? I'm interested to know.
Yes, doctor. See, since this child, see, I also explained the parents about the advantages of communicating the bad news to the child, everything. But they were so determined because the child is affected so much with the first diagnosis of a skin condition itself. We are so affected because he was not able to go to the school. He was bullied by his friends, and he was not able. He was limited to few physical activities. So the parents felt that revealing again the diagnosis of the cancer will make him more depressed, will make him will maybe lessen his communication also, because the words from the child, no, this 11-year-old child, whatever he tells, it will be very crisp and sharp. So he was so much affected by his first condition itself, the skin condition itself. So that is what I felt. Okay, maybe parents' consent is more important in this case. But to talk about to talk in general, I
Really?
feel it depends upon the parent and the child situation.
Mhm. Yeah. So yeah, I think we have very interesting points. People are writing. It's almost like a very good debate going on, and
Yes.
and that is what exactly. I mean, it's very. I really appreciate the responses coming here. You can also read that people are saying that as a human being, they have a right to know. If the adults have the rights to know, why would we think that a 12, 13, 14, 15-year-old child doesn't have the right to know? On the other hand, Niveen says that legally we are not allowed to tell the child if the parents don't want. So that is that is a thought that if it's a minor and there is a major
Yeah.
caregiver who doesn't want, probably it will be very difficult. I think is that maybe over time, I'm sure if it's a very short time, things will be very difficult. But if it's a prognosis which may mean 6 months or a year or sometimes 2 years, somewhere over the line, if we keep talking to the family and put this across, I mean, obviously, finally they will decide whether we should or not. that whether this person will go away without knowing, they may have their own emotional things to do, but I don't know. I'm not an expert in this children thing, but I'm just as a person, I'm thinking that this dilemma which I can see in the chat box is very relevant. And Avatar mentioned that child can't understand. So I think child Avatar, from mostly from the academic knowledge, not personal dealing. There's a lot of literature on this, that at some point of time you need to assess the child, their maturity, their culture, their ability, and maybe go along with that. Smriti, you want to say something on this?
Yeah, so one of the biggest myths about talking to children in illness settings is that they don't understand, or that they don't understand, they're too young. Every child has his or her own understanding. Someone mentioned IQ. I would go a little beyond IQ and say, look at their developmental stage at which they're at. A child who is 4 years old understands language and behavior and interprets the world very differently from a child who is 8 years old, from a child who is 10 years old. Very young children, and we've mentioned this before, very young children take language literally. If you say that, oh, what is your illness going to be like? You're going to sleep and never wake up again. The child will be afraid to go to sleep because they take it literally. They don't understand abstractions. When we tell children, like, we use a lot of metaphors and euphemisms when we're talking about illness and death when we talk to children. It's really a way to protect ourselves, to be honest, because none of us like to talk to a child about something so serious. And honestly, a lot of the times it's our fears that we're projecting onto the child. I would also say observe the child's behavior, because the behavior will give you, especially for children who are pre-verbal, or children who don't have the language abilities yet. But this child, Rama, you said he's a very crisp, articulate kid. I would look at the choice of words the child uses, and that will give me a hint to what he or she is thinking or feeling about the diagnosis. And really, let's not discount the parents here. The parents know the child best. Sit down, and it's not about us just going and telling the child. It's not that. I think it's a bit of a collaborative exercise with the parents, saying, what are you concerned about? How has your child coped in the past with XYZ situations? When your child gets stressed, what do you observe in your child? And then look out for those signs of stress. Look out. Children know when secrets are being kept from them. And please remember, children are highly imaginative. They will fill the gaps with their imagination, and often the imagination is far worse than reality. We've had children ask us if they will be eaten by worms and things like that. But it's really about us sitting with them, uh, going through that process with them, understanding their language. What are they trying to say? So there are many, many, many ways in which to engage a child. It's not just about disclosing to the child that he doesn't have a long time to live. It could very well be just, children ask landscape questions, and we will be talking about that when we'll be doing a section on communicating with children. Landscape questions are that they may not ask you a direct question. They might ask you something that fits into the larger jigsaw puzzle. They're really talking about an issue, but they okay, like, for example, a sibling will say, can I have my brother's toys now? It seems like such a selfish question, but really he's asking for whether he's going to get attention. When a child is sick, look at the sibling is also feeling neglected. So children, there are ways to communicate with them that are quite roundabout, but it is very, very possible. And that's just something that I wanted to put out there. And also look at the artwork, look at what they play with. It has been, literature will show you that children have an incredible ability to understand death and dying in their own way. And they have ideas of spirituality which might be very different from ours, but it might come across as magical thinking. And finally, the last thing I want to say, Param, before I stop talking is, children want information that is something that they can understand. You might have to go back to it several times, because it's in the early years that the developmental stages progress really fast. So in the following year, the way he or she understands, formal operational thought kicks in. They might be able to understand logical reasoning a little bit better. So you might find yourselves answering similar questions posted in different ways. But always, 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 I think a child requires reassurance. Irrespective of whatever is going on in their lives, a child has a deep sense of need for reassurance by his or her caregivers, including the healthcare providers. So whenever information is being given, it should be cushioned with the reassurance that no matter what happens, the parents are there, or that you guys are there, and
We are not
that
abandoning. They won't
yeah,
be abandoned. True, Smriti. I totally agree. Let's see if anyone else, Rama Lakshmi or anybody wants to add a point or so.
Yes, I want to add, say, acknowledging the feeling of the child is more important, I feel. And also in the chat, I can see, as many of them told, that maybe we can leave the parents to break the, communicate the bad news to the child when they feel that this is the right time that I can communicate to my child. Maybe that could be an option. Yes, that was my point on this thing.
True, that is right. That, yeah, I mean, they can go when they go for walks or talks.
Yeah.
As Smriti said, indirectly, talk about life and the the and finiteness of life slowly. I mean, it can be done slowly, and if they are not comfortable saying it as it is, I mean, we probably have to go. So I think, yeah, as many opinions, there is, I think, a very individual way of every family, every person to tell them.
Yeah.
And as Vandana's writing, it's very difficult for the distraught parents. Absolutely, that's what I said. Just at that time, I don't think we should. I mean, personally, I don't know what does the literature say. And this we're not in a hurry that the the child should know, because the parents actually are. It's a big shock for them to know anybody else or themselves going away than their child going away. So I totally agree, Vandana, that that is not the time possibly to talk, telling them to, or even forcing them or think about it. So maybe it's over time that we kind of can discuss this issue, just throw it up and say what they feel about it.
very often the parents are the last to accept the prognosis because they don't want, yeah. And so in a time like that, um, I've had instances where the child has turned around and reassured the parent that everything will be okay. So there's also that element that sometimes kicks in, and they surprise us. Children surprise us in beautiful ways. uh, there was also this time, long time ago, in another place where this child was imminently dying, and everybody was like, how are we going to tell the mother, how are we going to do this, basically assuming that she was distraught in a particular way. And finally, when someone took the time to ask her what she wanted, she just wanted to hold the child while he died. And she said, I just want to be able to be there, hold him. And that's all so all of this other stuff that we had assumed was basically our assumption. Yeah, that's.
So
Can I share something?
Yeah. So someone said, I'll just wait. Okay. The one thing I think we can talk to parents or think about it is that if not telling them, like, it's very important for loved ones to say byes. So if the child never knew, and a child was like, as 11, 12, 13-year-old, they will never get a chance to say proper, honest, genuine goodbyes. So that will be a big disadvantage if they never ended up telling the child. But again, as everybody said, it has to be tailored. Vandana, I think you were saying something.
I was once interacting with the pediatric kid who was 9 years old, and he was in the final few hours of his life, and the mother and the sibling and everybody was there, and we were talking, and the father was extremely distraught. He and I spoke for about 1 hour where I just listened. Somewhere in between, the child called me and said, I know I'm dying, and I would also like my parents to accept it. So that he was just 9 years old, and he was so perceptive. He says, I don't like it that they are crying all the time. I'm getting goosebumps. He says, I am going, and I would like to see happy faces. So that was his thought. He actually said it to me, that I know I am dying. So yeah, I mean, kids are extremely perceptive. They just know.
Well, once that barrier is crossed, as you said, they might have a chance to have very meaningful conversations and talk, and a bonding which memories might be left forever. So yeah, there is a thing, but tackling is, I guess, is the main point, how to best tackle it.
Also, I think one point that I mean, it's a pet point with me. I think I'll be bringing it up quite often. Whenever there's a child who is not well, I've said this before, it's so important to look at the other child who is healthy. And let's not forget about that child, because he or she usually unintentionally gets sidelined. And very often siblings are each other's confidants. So just there is a dynamic that emerges there also. It's always good to also check in with the other sibling. And so let's not forget the great that there's a whole thing happening there as well. And like I said, we'll be doing a session on children and communicating with children through different age groups further down the line. So we'll be happy to cover more of that.
You were talking about something like my sister's keeper story. Yeah,
It's
when
true
they
more
have a
often than
child, so they can save the other child, and the abandonment feeling the normal child goes through. Yeah, so that's something to think about, very important.
Yeah, and for all the mental health providers here, some of the biggest behavioral challenges we see are in children, the siblings of children who have been sick. So that's something for us to, I mean, we can prevent that level of suffering also if we are mindful.
Yeah, I know of a family who had a child again, some exactly like that movie and book, My Sister's Keeper, uh, a major uh, child who required a bone marrow transplant, and they decided to see if there was a match, the second child. Although, I mean, the both very loved, but that just that thought, sometimes if the child comes to know, can be, this something may have to be dealt with very properly. I guess I think we're just at times. Smriti, Manisha, you guys take over.
Yeah. Thank you, Param, very much. And thank you, Rama. Very, very clear presentation. Gave us so much to
Thank you.
think about and talk about, as you can see. And I think these sessions can go on.
Yeah.
But thank you so much. And we'll see you all next Friday, where we'll be talking about the psychological impact of pain. And that'll be led by Dr. Aju Matthew, who is a medical oncologist who's worked very closely with us for many years, and
Sorry, Smriti
that'll be
ma'am.
an interesting.
Sorry,
Yeah.
I'm interrupting you. So next coming Friday, there won't be a session.
Oh, sorry, my
Yeah.
fault.
It's
Oh,
okay.
yes.
Yeah. And then the next,
All
on
right.
30th, the session would be on community and palliative care.
So basically, I've got everything wrong, guys. Don't listen to me. So Friday after next is about psychological impact of pain. Yeah. So thanks so much.